Yeah, good. Thank you. Thanks for joining us tonight. I'm just going to do
Right.
all the beginning stuff that you've got to do before I talk to you. So bear with me. Okay, thanks everybody for joining us. Hello and welcome to the Fertility Show's Let's All Talk Fertility weekly webinar. This is the second in our live events, which we'll be hosting in the lead up to our live show. Weather permitting. I was going to say weather permitting, COVID permitting. We'll run in any weathers. On the 25th and the 26th of September 2021. I'm Sophie Solaria, your host for this evening. I'm a fertility patient myself, a journalist. I'm the creator of the fertility podcast, The Long Road to Baby, on BBC Sounds, iTunes, and to be honest, anywhere that you get your podcast from. So do check that out. And I'm also the ambassador, if you can see on my t-shirt, for Peanut. Now, Peanut is a social networking app for women trying to conceive, and it supports you through to motherhood, otherwise known to me as community in my pocket, because literally you can pick up your phone at any time that you need somebody to talk to, and you can log onto the app and there they are, all these wonderful, wonderful people who are at a similar stage in your life, ready to support you, to build friendships with you, and to just give you lots of love and advice. So if you haven't done so already, I do urge you to download the app now. And when you do, make sure that you join the Fertility Shows group in there, where I personally hang out regularly. It's there to provide you with lots of advice, information and support, plus all the information about the seminars coming up too. And I'll be in there after this chat to answer any questions that you have as well. I think it's also important to note that these webinars are being brought to you completely for free. We are never going to charge you for this type of information. By the Fertility Show in association with Fertility Network UK, which is the national charity, and it's also partnered with Fertility Fest, which is run by my excellent co-host, I know she's watching now, Jessica Hepburn, and Jessica will be back in a couple of weeks' time for our first ever book club event with the wonderful Sarah Banks and her book, The Positivity Planner. So first, though, let's get on to tonight's proceedings. And this month, we're focusing on starting out with fertility treatment. Tonight, we'll be talking to the wonderful James Nicopoullos from the Lister Fertility Clinic to try and determine what we should be asking our doctors at the start of our treatment. Good evening, James. Thanks for joining us.
Pleasure. Thank you for having me.
No, wonderful. Can we start by you introducing yourself, if that's okay?
Yeah, my name's James Nicopoullos. I'm the clinical director and person responsible here at the Lister Fertility Clinic, and long-term supporter of everything that you guys do, really, at the Fertility Show, Fertility Fest. They've all been just a fantastic addition and source of information for everybody that really struggles to get genuine, honest information from impartial sources. So you guys do an amazing job.
Thank you so much, James. So for those watching, here's how our seminars are going to work. We're going to ask James 5 questions in the first part, and then we're going to give you a chance to ask your questions as well. So please, can you write them just up there in the Q&A function? We won't be going live to anyone tonight, and they can remain anonymous, but we will try and get through as many questions as possible before we wrap up. Thank you, James, for staying on to do that a bit later on. So let's get started on the first 5 questions, if you can. And number 1 is, what are the most common reasons for people not getting pregnant?
Okay, I think frustratingly still in 2020, the commonest thing that we find is that we don't find a cause. And in about 30% of couples, we still find unexplained infertility. And it may be that that proportion is still high because we're better at investigating people, but actually people are starting later, and actually there's no other concerns apart from that. It may be that we practice prehistoric medicine and we look back in 50 years and think, what on earth are we doing? There are some better tests now that we're using in younger couples where there's no cause of fertility, that I'll come back to later, like sperm DNA and things that actually may be making us better at investigating. But there's still a chunk of people where we don't find a cause. If we do find a cause, the commonest thing is a sperm-related problem. About 25% of couples who struggle, the problem is almost completely down to male factor, and some sort of male factor probably affects another 25% of cases. Thereafter, probably around 20% of cases, the problem is irregular cycles and women not ovulating, classically something like polycystic ovaries, quite easy to hopefully sort. Then probably blocked tubes. About 15% of couples probably have some history that has caused the tubes to be blocked. And probably the remainder, 5 or 10%, is some sort of gynecological problem like endometriosis that can obviously have a massive impact on quality of life, but also have a negative impact on people getting pregnant. And it's worse because it scars the pelvis and blocks the tubes. And sometimes just because of that slightly horrible inflammatory environment it causes in the pelvis that isn't really friendly to eggs and sperm. I think that kind of covers the whole plan.
I'm actually quite shocked to hear it's second most common is male factor, but we're actually going to be covering male factor fertility throughout the whole of February. So
good.
I urge people to look out for that. James, thanks for that. Number 2 is, how long do you think that people should try to get pregnant naturally before going for tests and coming to you for treatment?
Oh, that's a really good question. Thanks for putting me right in it there. I don't think there's a right or wrong here. I really don't. I think my gut feeling is that I don't think at any age you should probably try longer than a year before you at least have tests. And it may be that at a younger age it's just reassurance and to allow you to keep trying a little bit longer. But obviously, I think the age you are is the key factor here, because your chance of getting pregnant naturally goes down as you get older. Really hard to quantify, but let's say roughly 80% in the year at 30, maybe 40% in the year at 40, and that's going to go even lower in the second year of trying. So, it may not be the end of the world if you test yourself after a year at 30 and find out you have blocked tubes the whole time and you've wasted a year, because the chances are still going to be really good. But if you waste a year at 40 only to then find out there was a really bad sperm problem or blocked tubes, you'd be really kidding yourself. So I definitely wouldn't leave it longer than a year at any age. And there's a real argument to say, especially as you get a little bit older, do you just do a little bit of a fertility MOT before you start? So you're not wasting it. You're picking up any problems before then. So you're not wasting time and you look back and kick yourself.
Tell us a little bit more about this MOT that we can get.
Yeah, people call it MOT. They call it all sorts of things. I think we call it a fit for fertility, whatever it might be. It's just an assessment, as I say, just to make sure there's nothing there that may impact on your chances, so you're not wasting time. Perhaps the most important thing that I'll probably come back to in a minute is looking at your egg reserve. So it just gives you an opportunity to come and have a quick chat with somebody after 2 or 3 tests, just to give a rough idea and some reassurance that, yeah, everything looks good. And more often than not reassures, but very occasionally it might pick up that 1% of men with no sperm at all, or it might pick up that woman with a low egg reserve for no reason. And it's useful to know now rather than if you've been trying for 2 years.
So you're really saying there that knowledge is power, because obviously some people would go for these tests and they might find out there's an issue and then be panicking for the whole rest of the time that they're trying. So it is that fine balance, but ultimately knowledge is power, is what you're saying.
But I think that's where we have a real responsibility. I think it's our responsibility to give the information in a constructive way, because I never want anybody to leave this room stressing out. I think if it's great news, I can reassure people, yeah, you don't have to absolutely start trying tomorrow. When you do try, there shouldn't be a problem. But equally, if we do find something that people don't expect, it's making sure that we make people leave here with a plan, understand how they can still make it work, and what steps they need to take to achieve that. What we don't want people is to leave in a blind panic.
So the third question is, what tests do you have to have first, and what will they tell you? So I guess the MOT comes into that, but I guess a little bit more information then about what they can tell you.
I think there's probably a question that we often ask doctors when we interview them to come. Lots of people come and want a job with us, thankfully, still. Is one of the tests we often ask is, if you had to do one test on a couple when they walk through the door, what would be the most important one? And we often get lots of different answers, but to be honest, there's 3 probably key tests that everybody should have. Probably the one that covers the most bases is a scan, a transvaginal scan, because number 1, that will give us an idea if there's any obvious gynecological problems that might impact on fertility, big fibroids, a polyp, some big endometriosis, cyst, or something like that. It'll also give us an idea of one of the important markers for assessing egg reserve. And the most important thing really in any individual or in any couple is what's going on the ovary, because to a certain extent everything else is reversible. If somebody's got blocked tubes, we can overcome it with IVF. If somebody's got really poor sperm, as long as we can find one sperm per egg, there's always the option of doing ICSI. We can usually make that work. What we can't change is that egg reserve. So that's the key. And by scanning somebody, we can actually count how many little follicles with eggs we've got in there recruited every month. And in essence, the more eggs someone's got left in their stores, the more we can see on scans. So that gives us a good idea of where we are. So that's test number one. Test number two is the other really good test of egg reserve, is a blood test called AMH. And again, that's a hormone that's produced by the little follicles there you've got growing. So the more eggs in your stores, the more come out every month, the more hormones churned out. So those two tests are a really good stop check of your egg number. It gives us an idea of where you are compared to somebody for your age. And the key really with those two tests is there's no normal, because a 20-year-old has got more eggs than a 50-year-old. It's really important when we look at those tests, we're comparing you to what you should be for your age, because people often get really stressed out because they go online and they start Googling it and they start comparing themselves to the normal range for a 20-year-old. And the third important test, most important test, is a sperm test. It's still a relatively blunt tool in that you can have really normal sperm numbers and it still may not be enough information, but it gives us a really good early indicator that there's enough sperm, it's moving okay, and it looks okay. And those are the initial ones, and if that's normal, then you can start assessing the tubes. And the one other test I'll talk about briefly now, and you guys, I'm sure, will talk in more detail next month, is that you can have absolutely normal sperm numbers, but the proportion of sperm that have got subtle levels of DNA damage can still be affected. So in that group of couples who are young with no other cause of fertility and seemingly normal sperm, it's really important that you assess the sperm DNA. Again, so you don't come back 3 years later and realize there was a problem that you could have done something about. And that's where it's really key to involve our urological colleagues, because although I'm a gynecologist who's done lots of research on male fertility, still gynecologist, and urologists, again, there's 2 or 3 that really specialize, as you know, in fertility. So it's important that we all work together to look at these couples in tandem.
I mean, those tests are really important when it comes to the point where we come to you, but is there anything that patients can do to get themselves ready naturally for pregnancy and indeed improve their chances with the IVF, which I'm sure is one of the killer questions you get every time?
It is. And the real problem with that is that there's so much out there that you can read about, but there ain't much out there that really has been shown to make a difference, frustratingly. There's lots of things that you can do that won't do any harm. Whether they really do a lot of good is really tricky to know. Clearly, a well-balanced diet, clearly, with a BMI probably above 30, there's a little bit of evidence that there's an increased risk of miscarriage, not necessarily pregnancy effects, but miscarriage. So again, perhaps keeping the BMI relatively normal. Smoking is the one thing I'd be screaming from the rooftops about, because we know it impacts on the genetics of eggs and sperm, possibly makes you have menopause a little bit earlier. I've got to be honest, I'm a little bit more chilled out about alcohol. Nobody has shown me that 2 or 3 glasses of wine or 2 or 3 times a week makes the blindest bit of difference on outcome. A lot of couples are going to want to stop completely understand that. But I think the key is I wouldn't be beating yourself up about having alcohol at that sort of level of intake. And a nice study showed that it may not impact on outcome. Lots of talk about supplements. General multivitamins. Vitamin D is probably the one that we're all quite low on. Statin is a very reasonable supplement to take. There on in, not a lot of evidence of benefit in much else than that. And obviously,
it's hard, isn't it? It's because all you want to do is fix it, but then in another way, it's almost nice to know that we can still live. People can still live and go through treatment, because, as you say, who doesn't want to have a glass of wine on a Friday and not feel guilty? So,
well, at the moment, on a Monday, Tuesday, Wednesday, Thursday,
and the chocolate and all the other things that's bad for you. No, life's bad enough when you're going through fertility treatment. Treat yourself.
And don't beat yourself up about stuff. That's really important.
Absolutely.
The other thing is stress, really. And the other thing I'd say is don't be stressed about being stressed. It's a really yes, it's great not to be stressed from fertility or from other life stuff, but sometimes life work is stressful, and it really there's lots of studies out there, not the most fantastic, not the easiest thing to interpret, but the best studies aren't really suggesting that stress is going to impact on the genetics of the eggs and the sperm. So again, don't beat yourself up about that.
And quickly, what about alternative remedies? So, loads of people talk about acupuncture and,
I'm really chilled out about all of that. And I think that the key for me, with my medical hat on, is that if it's going to improve your stress levels and your quality of life, doing these things, absolutely grab hold of whatever you can. If the thought of somebody sticking a needle in you is going to stress you out, then clearly don't do it. There's a little bit of evidence that acupuncture, as an example, can improve your blood flow to the lining of the womb. Whether it really improves IVF outcome, fertility, difficult to know either way, but it's definitely not going to do any harm. So again, it's about choosing what's right for you.
For me personally, it caused me so much stress getting to the appointment before having to get to IVF, and I didn't like needles in the first place.
Yeah, you're a perfect example. Yeah, but some people will say that hour on my own without the world, giving me stress is actually my time, so it's good. So it's really a personal choice.
Our fourth question, James, is what the success rates are for IVF, and this is a difficult one, isn't it? Because people almost hinge themselves on what clinic they choose based on this question.
Yeah, I think it's a really, really good question. The problem is that it's very hard to interpret the data. Dare I say it, the HFEA, despite trying to make it easier, I'm not sure how. They've made it worse sometimes in the way that they stratify it. And again, dare I say it, there are some ways where clinics may look better than they really are. Silly example, if you read data for success rates in women between over 37, if you're a clinic that doesn't treat anybody over 40, your success rates are going to look great over 37. If you're a clinic like ours or others who treat everybody as they come through the door, then so it's very hard to compare. I think the best marker is, the other thing is obviously putting more embryos in increases risk, but may make your success rates look better. So the new way of the HFEA are recommending that we publish and patients look at data is live birth per embryo. So for every 100 embryos you put back in, how many babies are born? And so that eliminates the impact of patient selection, eliminates the impact of putting too many embryos in. So that's a nice way of looking at it. But realistically, I'm in London, so for me, I'll talk about London just because I happen to be here. If you walk into 4 or 5 of the good clinics in London, and word of mouth is really, really important, the chances are your success rates are going to be very, very similar. And I think the key is going to open evenings, getting a feel for the place, listening to people, and going where you feel comfortable, because I think that is a really, really important factor.
Absolutely. So when we're looking at these kind of statistics, what are the most important ones, and how do I understand them?
I think pregnancy rate is important, but I think live birth rate is more important.
Live birth rate.
Yeah, absolutely, live birth rate. Looking at live birth rate for your particular age group, but again, just be aware that it's sometimes worth looking at it in more detail. So don't just look at it over 37, under 37. Look at it for your particular age band. You can delve a little bit deeper and look at that. It's probably worth looking at twin rates as well, because you want to choose a clinic that hasn't got a twin rate of 35%, because our aim is to get you guys home healthy with a healthy baby. And the best way of doing that for your sanity as well as your health is not by giving you twins or triplets. And most of us should be having twin rates below 10% now. So it's finding a clinic with a good success rate, but also one that minimizes risk. And in terms of overall success rates, really, the key factor is age, and success rates under 35 in a good clinic are going to be 45 to 50% for the live birth rate, and that kind of slowly declines with age.
Okay, right. This is the next one. This is a big one. It's really important this year in the light of the current pandemic that we are living and breathing, and the vaccine, of course, becoming available. What do you recommend for those trying to conceive or having fertility treatment to do about being vaccinated, James?
Okay, that's a really, really good question. And the goalposts changed with more data. Pre-Christmas, what was being said changed. So the current recommendation, and this, I think the key is, although this vaccine is relatively new, it fits with the other vaccines that we know aren't live vaccines. And the recommendation is really clear. If you have the vaccine, you do not have to wait until you can get pregnant. So the first thing to say is, if you're called because you're high risk to be vaccinated now, please, please, please go and have the vaccine. You can still try and get pregnant straight away. So that's an easy one. But most women of childbearing age aren't going to be high risk unless they're key workers or they've got other underlying problems. So they're probably going to be called in 2 or 3 months. So the question for that group is, what do I do? Because from the second dose, you do have to still wait. So if you get pregnant after the first dose, you have to wait for the second dose that gives you full cover. So that is a really, really tricky question. My gut feeling still would be, honestly, almost eliminate the vaccine from the equation. If you're trying naturally, carry on trying naturally. If you're planning IVF, get on with your IVF, because although there is a massive amount of data, we're not seeing an increased risk of problems in pregnancy if you do get COVID. If you then get called for your vaccine, yes, have your 2 vaccines, stop while you're actually in between those, and then come back and then get cracking afterwards. Because at the end of the day,
come back how long?
As soon as you have your second dose, you can go again.
So seriously, so you can have these vaccines, come back, get treatment. I mean, we're hoping that your doctor will obviously advise on this anyway once you go in and blah blah blah. But ultimately, it's a concern because and of course the other concern is during the pandemic, are clinics going to be continuing to operate? We already know there's a reduced service, but will you still take people throughout this year as it gets worse?
I think that everybody was caught cold last March. I think none of us, we were all sitting there, watching the news in Wuhan in January thinking that's not us, unbeknown to us what was going to happen a couple of months later. So very sensibly when, everything started heating up last March, the HFEO told us all, we'd all stopped already, most of us, but to stop for 2 months. When Matt Hancock stood up on that Friday in May last year and said you can restart, we were actually a little bit surprised but delighted. Us as a clinic, because we were contracted with the NHS for those 2 months, we were doing all the emergency early pregnancy work for the NHS. We had already set out all the safety measures, the PPE, the staff testing, the triaging, the patient testing. So we hit the ground running straight away. And every clinic now has to have those measures in place to be able to keep working. And the HFEA have made it clear, as recently as the 5th of January, that as long as you've got those measures in place, you can carry on treating people. So the key factor is, are those measures in place? So yes. And the second key issue is to make sure whatever we do here in a private clinic isn't burdening the NHS. So we're obviously being uber cautious to make sure people do miscarry. Unfortunately, people do have complications. We're not burdening the NHS. So those 2 are the key factors. Is it safe? And at the moment, it's as safe as it can be. And to make sure we don't burden the NHS. So the answer is we're still here. I don't think that'll change. So we just have to just manage obviously workflow and processes just to make sure we keep it as safe as possible. And
the bottom line is, if you get offered a vaccine, take it, and the rest can be sorted out. And the delay shouldn't be.
No, not significant, because
not significant as getting corona.
Exactly. As much as time is of the essence, 6 weeks, 2 months is not going to be a deal breaker here. It really isn't for your fertility.
Thank you, James. We're going to move to the question and answer part of this evening. So again, if you haven't already got your questions in, you use the little box above and type your Q&A in. Laura's there to ask you the questions now. Laura, can you hear us? Are you there?
I am. Can you hear me?
We can, Laura.
Okay.
Can you start? Yeah. What kind of questions are coming in tonight?
Well, we've got various questions, a couple around COVID. So I'll go to those as we were just following on from that. There's a lady here asking about her partner. And obviously, will the COVID vaccine have an impact on sperm? I don't think you covered that, James. Does it have an impact on the men, do you think?
The answer is the evidence is really, really limited, and actually there's nothing there that I can think of in terms of the way a vaccine would work that would have a significant impact at all. So we haven't had any significant recommendations to suggest there should be any issue with the. Similarly, with taking the vaccine, if you're trying to get pregnant, once you've had the vaccine, you can carry on with trying to get pregnant. It's going to be the same thing for a man. I haven't seen any data that would concern me at all about that. So again, especially if you're shielding and high risk, please have that vaccine. Reading the question here.
Brilliant. Thank you. Laura, are there any more?
Yes. Our first question of the evening was, how long do you recommend between finishing breastfeeding and starting a cycle?
To be honest, once you stop breastfeeding, whenever you want, really. In most scenarios, treatment starts with the beginning of a cycle. So it may take a little bit of a delay for a cycle to come back. But even in those scenarios, we can still be a little bit creative, for want of a better phrase, and induce a period to get you started. So it doesn't really need to be a significant delay. Whenever you feel physically, emotionally ready.
Gosh.
And with a toddler at home, whenever you can do it.
Yeah, exactly. Do you want to? No, I'm joking. Yeah. Of course you do. Laura, what's the next one?
Thank you. What is the success rate of IUI for women over 40 years old?
Yeah, really good question. And as most of you will probably know, simplistically, as long as you've got normal tubes and a reasonable sperm count, simplistically, IUI is lower cost, lower hassle with a lower success rate. IVF is a higher cost, higher hassle, and a higher success rate. Some people will want to go up the treatment ladder step by step. Some people will want to go straight to what's going to give them the best chance. And everybody will be slightly different, and that will be a real personal choice depending on various factors. And I've avoided answering the question there. If you like the way I managed to do that. Over 40 is a real wide range. So, if you look at the success rate of IUI around 40, for example, it's probably going to be around between 7 or 8%. The success rate of IVF around 40 is going to be 25%. As a comparison. And as you get a little bit older, by say 44, realistically, IUI success rate is probably down at around 1%. So, not fantastic.
It wouldn't be your advised preference if you were to come to you over 40?
No, I think that, for a single woman who has a 0% chance naturally, it may be a very reasonable first step before she thinks about something more invasive. And for some people, that would be right. But most people over 40 are going to want to crack on with IVF.
Yeah. Thank you, James. Laura?
Yeah. This lady has been diagnosed with unexplained infertility. She's had extra tests for RPL. Is IVF the best treatment versus trying IUI first? She's aged 33.
Yeah, so I'm assuming that's recurrent pregnancy loss, so miscarriage. I think that if she's been trying for a significant duration, again, IUI success rate is probably going to be around 10 to 15%. The key factor, if you've got unexplained infertility and you're that young and there's no other cause, clearly unexplained, is to get a sperm DNA test. Because if the sperm DNA is high, we know that the chances of getting pregnant naturally or with IU or IVF are significantly lower. So that would be the first thing I would do. And then really probably think about IVF, depending on how long you've been trying. I think that's the key factor. The only other thing is that if you have got a recurrent pregnancy loss or recurrent miscarriage, the only other thing to say is that the option of IVF does also give you the potential benefit of genetically testing the embryos and trying to eliminate that miscarriage risk. Won't improve your chance of ending up with a baby because the embryos are what they are, but it will stop you putting an embryo in that's abnormal.
That's good advice. Thank you, James. I hope that's answered your question. Laura?
Yeah, I've got a lady here who's 42. Her partner has problems with his sperm and they were on the list for fertility through the NHS. We were told that they could not conceive naturally due to her partner's low sperm count. During lockdown, however, the lady conceived, but sadly miscarried at 10 weeks. Would that, James, have been due to the partner's sperm issues, do you think, or something else?
Yeah, I think there's a couple of things to say. I think that unless a man has got absolutely no sperm, I don't think anybody should ever be telling somebody they can't conceive naturally with a sperm count. I think it just takes one of the little blighters to get the job done. And yes, you may have 1 million rather than 20, but it's still possible. So I think, that's a real, I don't like that statement, because clearly you can see it can happen. Yes, it may take a little bit longer compared to somebody else, but it's very rarely zero. And kind of the age of the female partner will help you decide how quickly you act on that. The vast majority of miscarriages are as a consequence of a genetic abnormality in the embryo that got you pregnant. And the majority of those come from the genetics of the egg rather than the sperm. So it's really, really unlikely that it's sperm related. Again, sperm DNA can play a factor, but it's much more likely to be, in essence, miscarriage, as horrible as it is, it's the body's second level of quality control. It's making sure an abnormal embryo that got you pregnant doesn't carry on. And although it's horrible and we often beat ourselves up and ask ourselves, what have we done? It's usually the body's way of doing the right thing. And miscarriage, about 40–45% of pregnancies in your early 40s are miscarrying. There's probably nothing underlying or anything to worry about.
It's just awful, isn't it? Especially on top of the COVID. We are thinking of that person that asked us that question. Thank you. Laura?
Yeah, I've got a lady here who is she wants to talk about ovarian stimulation drugs. She's not had her first consultation, but the clinic says they use Clomid or tamoxifen. She's had side effects from Clomid in the past, blurred vision and worse, and had to stop. Do you think she may get the side effects on tamoxifen, or is it a different type of drug?
So what was the initial part of that question? So she's been offered the option of
Clomid and tamoxifen, and Clomid made her unwell, I think. And
what was the cause of the infertility?
She doesn't say.
Okay. Well, I think the key is Clomid is a drug that induces people to ovulate. Sometimes it's slightly thrown around like confetti where there isn't a cause, because sometimes people feel the need to do something. And there's no evidence of any benefit. If you've got a regular cycle and you're ovulating, you shouldn't be getting Clomid. You really shouldn't. If you have got a problem with polycystic ovaries and you're not ovulating, the first line drug actually should be something called letrozole. Works in a very similar way to Clomid and tamoxifen, less side effects, and it's been shown to be more beneficial. So actually, if you've had problems with Clomid, letrozole should be the one you should be going for rather than anything else. And it may be that you do have less side effects on that or tamoxifen than Clomid. But letrozole is the one I would go back and ask for.
The side effects of these drugs are bizarre sometimes, aren't they? Somebody could be fine on one, and somebody could have migraines and sweats and all kinds of
sorts. Absolutely.
There's so many different kinds. It's really worth having that chat actually with your doctor if you're having those kind of feelings. Laura, I think there's loads coming and I can see them. Any more?
Yeah, I've got another one here. Following on a little bit from that one, James, this lady's been diagnosed with low ovarian reserve. Where does that fit in the terms of the reasons why she's having fertility problems, and what does that mean in how it affects her struggle to form?
It's a really good question, because in many ways I mentioned how important egg reserve was, but I also didn't mention it at the start as a cause for infertility. And in essence, if you imagine that, in any given cycle, a woman's got a certain number of eggs ready to grow, and one of those ends up winning the race, and you release the 1 egg a month. Yeah. So as long as you've got a regular cycle and you're doing that, whether that 1 egg that's released comes from a batch of 15 and a woman that's got a good egg reserve, or whether that it comes from a batch of 5 and a woman that hasn't got a good egg reserve, actually, your chance of getting pregnant naturally shouldn't be any different. Make sense?
That's interesting.
Where it becomes important, though, is that, if you've got only 4 or 5 every month, the chance of plan B like IVF working is less. The timescale you've got before the success rate drops off more is less. So the key is, as long as you're ovulating, as long as everything else is okay, your chance of getting pregnant naturally is probably very similar, but you should probably think about moving to plan B quicker if you've got a low egg reserve. That makes sense?
I was always told it's like a conveyor belt.
Yes, absolutely. Yeah. I always talk about, it's a really bad analogy. If you imagine you're in an airport, bear with me. You start off with thousands of eggs in the beginning of that walkway that takes you to the gate. And of those thousands, only about 10 or 15 end up getting to that departure gate and they're ready to fly. And in any given month, one of those ends up being the ones that flies away and you ovulate. It works in my little brain. It probably makes no sense to anybody else.
Well, it makes sense to nobody because nobody's going to any airports and flying off anywhere.
Yeah,
so
true.
you know, you'll have to think of a new analogy for this year.
I will. Okay.
Laura.
Yeah, here's our next question. Is there any increased risk of miscarriage when having IVF?
Yeah, I think the answer is the best studies are suggested not, in that, you know, your miscarriage risk is really dependent on your age. So if you're 35 and you get pregnant naturally, or you get pregnant with IVF, the overall miscarriage is the same. You know, sometimes if somebody does IVF, they'll do a pregnancy test bang on the day, and it may be faintly positive, and 2 days later it's negative. And in IVF, you could call that a pregnancy and a really early miscarriage. If you were trying naturally, your period just would have been 2 days late. You don't classify it the same. But overall, we're not seeing a difference.
And actually, whenever it comes to having the baby, once you've been through IVF, the doctors always suggest that you get induced or have that baby before 40 weeks because something to do with the placenta. Is that something you agree with as a consultant?
Yeah, I think frustratingly, sometimes it's not always suggested. And I think that we don't know why, and it might not necessarily be the IVF, but there is a suggestion that there may be an increased risk of problems later on in pregnancy, even if you get pregnant naturally and you've struggled to get pregnant. So it may not be the IVF, it may be some underlying problem in couples. But yeah, I'd say, you know, don't wait till the classic 2 weeks overdue to be, be induced at 40 weeks.
Thank you. Laura.
Okay, age has come up quite a lot this evening as being a factor. This lady is asking, she's got unexplained infertility. She's had it for 2 years, having had 1 miscarriage and 1 live birth. And she's starting her first IVF at almost 43. What are her chances? Are the chances higher because of her age? But
I think obviously, age is the key factor. So success rate will be a little bit lower as you get a little bit older, as you know. But one of the positive predictors is a previous baby, because often we go into this a little bit cold. We don't really know what the quality of eggs or sperm is going to be, and the fact that you've had a baby, clearly tells us that those eggs can get the job done. So it's definitely a positive predictor. So be reassured by that.
That is good. I just saw a question flash up a second ago that said, could you repeat that? And I think it's worth saying that this webinar will be online to view on our YouTube channel pretty much as soon as tomorrow afternoon, whenever I've got it up there. So if you haven't heard anything, if you need something repeated, do watch it back on our YouTube channel after today. Sorry, next question, Laura. Thank you.
Great, thanks, Sophie, because there is a lady who's asking about breastfeeding. So go back and ask.
Yeah, you missed it. Yeah, that's good.
Okay. Right. Next question, James. Should your fertility clinic automatically test your thyroid function?
Should it? Every clinic's different. I'm not going to make a judgment. We do. We feel that there's enough evidence to suggest that although your thyroid could be normal for overall health, if it's at the wrong end of normal, in early pregnancy, the demand on your thyroid is a little bit higher. There's a little bit of evidence that if it's not in that perfect range, it may have a small impact on miscarriage rate. The data is a little bit variable, but going through what you're going through, putting yourselves through, we want to be uber cautious. So the answer to me would be yes.
Thank you. Are there lots more to go, Laura? Because we're a little bit near to time, but if you have a few more questions, we can answer. And if we can't get to you, we will get to you after the event. So don't worry.
We have got a lot of questions. I'm doing them in time order, to be fair. So we'll carry on, and then as you say, Sophie, we'll answer them when we can.
Yeah.
So, James, would you recommend removal of fibroids before starting IVF after a miscarriage and failed IVF cycle?
It all depends what the fibroids are. Lots of different kinds of fibroids. If the fibroids are within the muscle of the womb, on the outside of the womb, then no. If the fibroids are coming inside and impacting on the lining of the womb, absolutely, because we know that high success rate. So it all depends where they are.
Thank you. Laura.
Okay, just one around the vaccine again, James. This lady is asking, she thinks you said to stop trying between the first and second dose. Was that correct? She works for the NHS.
No, I said if you can absolutely, you can carry on trying, but if you do happen to get pregnant after the first dose, they won't give you the second one. So if you have the first one, you may make the decision, actually, I've had the first one, just in case, let's get the second one in, maximize my immunity, and then get cracking.
The ultimate end point on that was just keep trying and just keep doing IVF, but you just might not get your second vaccine is all. Yeah. Laura.
Okay. Can you explain the difference between long and short IVF protocols, please? And in which circumstances would somebody need one over the other?
Okay, there's lots and lots of talk about protocols. And honestly, if you do really, really well, we'll say how clever we are. If you do badly, we'll kind of probably blame your ovaries. The truth is somewhere in the middle. If you've got a good batch of eggs in any given month, the overall data suggests the protocols are probably around the same. But whatever protocol we give you, the medication to make the eggs grow starts just after your period, okay? If we just give you that and nothing else, your brain will do what it does every month, realize you've got these lovely eggs growing, and you'll ovulate and you release them. So we have to give you something else to stop that from happening. And that's the difference between the two. In a long protocol, that's an injectable or a nasal spray that starts a week or so before your period. In an antagonist protocol or a short protocol, that medication starts for the last few days before egg collection, works straight away to switch you off. Classically, the short protocol is used either in a woman with a very, very low egg reserve, we don't want to switch her hormones off, or in a woman with a very, very high egg reserve, where it gives us clever tools in our armory to minimize hyperstimulation. And that really will depend on your age and your egg reserve.
Thank you. Laura?
Okay, this lady's been diagnosed with subfertility after trying for 3 years and having 2 miscarriages. Her last miscarriage was 18 months ago. When should she start IVF?
Did she say how old she was? Sorry.
She doesn't say how old.
No. I think after 18 months, 18 months after the last pregnancy, probably at most ages, should you really be considering fertility treatment. Especially if you're getting significantly beyond 35, 36, 37, I think 18 months. Again, the other benefit potentially would be the option of genetically testing embryos to minimize that risk of further miscarriages. As I say, it's not a recommended test to do routinely on everybody. It hasn't been shown to improve baby rate. It would just be for that, physically, emotionally, I don't want to put myself through it again. I don't want to waste another 4 months if I'm miscarrying. But I think probably getting to the point where you should think about trying.
And if you do have a patient that's come to you that with recurrent miscarriage prior to seeing you, is there anything that you do for them within the pregnancy should they fall pregnant?
Yeah, it all depends on the majority of recurrent miscarriages. Really, it's again just the body's way of saying every time this wasn't right. But I think you do need to rule out hormonal problems like thyroid, subtle clotting problems, subtle genetic problems, anatomical problems like fibroids. So if we find any of those, then we'll treat those in early pregnancy.
Great. Laura?
Okay. 1 second. Can you tell us more about PGTA and how many patients you now see opting for this?
What is PGTA?
So PGTA is what we were saying earlier, pre-implantation genetic testing of the embryos. So it's what I was saying. So you collect the eggs, you fertilize them, you grow the embryos to day 5. Instead of just putting the best one in, you take a little biopsy of the cells, you freeze the embryo, get the results back 10 days or later. If you have a normal one, you can put it back in the month or so after. Again, doesn't improve the endpoint of baby because testing them doesn't change them, but it gives information. The potential negatives are that 1 to 2% risk of damaging the embryos, probably less than that in good hands. The other potential negative, as I said, is not changing the endpoint. There is a tiny risk of a nice embryo not surviving the freezing and the thawing, but again, negligible risk of that, but there. And there's a small negative in terms of cost. So you've got 3 options. Option number 1 is just to put the best one in, like most people do. Option number 2 is say, I want this information, especially if I had a previous miscarriage, so I'll test them all and freeze them. Option number 3, which I quite like, is you put the best one in. If you happen to have any others left over and you're freezing them anyway, then you test them, because actually you're freezing them anyway. You don't want to then come back emotionally, physically, financially use an embryo that's not genetically normal. So actually it'll be useful information then. I think in our hands it is increasing, despite the HFEA increasingly saying we're not sure whether you should be doing it. because I think people are well informed and they see that this is the one area where there is no right or wrong. Probably about 10% of cycles at least start out thinking about genetic testing.
And whenever you unfreeze or thaw out or whatever you do with these embryos, are they nowadays still quite good, I guess, compared to a live embryo, the one that you get at the beginning? Are they the same quality still now?
Yeah, we try and do as much as we can with a really good evidence base, and often there isn't a lot of evidence for some things, but there really is fantastic evidence from massive trials now that frozen embryos do as well as fresh. For a while we got really excited they may do better, and we're not really seeing that, but they definitely do as well. So, you know, if you have to, for any reason, it's not a problem.
And what about freezing eggs without getting them, making them into embryos? The technical
this egg freezing. So before this, I just did an egg freezing webinar. I've had a busy night, and increasingly the data suggests frozen eggs probably do as well as fresh. The problem is a lot of women have frozen their eggs. Not that many women come back to use them. So the number of babies born is a lot less than with embryos. So we haven't got that direct data. So it's much better than it used to be. It's probably as good or almost as good as fresh, but we haven't got the same level of certainty as with embryos.
Because it's almost like an insurance policy, isn't it, for women, really?
Yeah.
And a good one, actually.
Yeah.
Laura.
Happy to take some more questions?
Yes, please. Well, I don't know, actually. I mean, I am. James?
I am. Yeah, I'm fine. I'm fine.
I'm fine.
It's not as everyone go to the pub or go out for dinner or anything. It's just,
what else have we got to do, you know?
This is the best thing I've had for ages.
Okay, good to hear that. This person has been told that they have a bulky uterus. Can you explain the impact this may have on fertility, please?
It's really hard to know what they mean by that, really. I think that,
I've never heard of that term.
Yeah, you sometimes see that on a scan report, and classically, that might be just fibroids making it bigger. And if they're within the muscle and not within the lining, they probably don't make a difference. Sometimes it's something called adenomyosis. And so endometriosis is the cells that line the womb that manage to find their way elsewhere in the tummy and cause painful periods, painful intercourse. Adenomyosis is when the cells that line the womb manage to find their way into the muscle of the womb, and it can make you look a little bit bulky. And again, classically, period pain. There isn't a lot of evidence, but some studies have suggested that adenomyosis may marginally negatively affect IVF outcome, but it's marginal, and don't panic if everything else is okay.
Good. Never heard, honestly, never heard of it. Some of these ways these things are called are very, very strange. Laura.
Okay, around Clomid again, James. Is there a maximum amount of Clomid you can have in a lifetime if you have, this lady has PCOS?
It's licensed for 6 months, but you know, with sensible counselling and advice, you can take it for longer than that. The studies suggest that the cumulative chances of having a baby does increase until you've been taking it for about a year. So in any one go, I wouldn't want you to take it for more than 6, maybe 12 months. If you get pregnant and come back again, you kind of almost reset the clock to a certain extent. So it really is just making a decision based on how old you are, you know, how many times you go for it.
Thank you. Laura?
Okay, is there anything you can recommend to improve the thickness of the endometrium, whether food supplement or anything medical?
This is a really tricky one, and most people don't know they've got a problem with the lining of the womb until they're doing IVF, and it's not getting to that magical 7mm line. And it's a really, really tricky one because there's been nothing that's been shown to absolutely work with any certainty. We often use extra estrogen to help with the lining of the womb in an IVF cycle, and stimulate people slightly harder because the more estrogen you get, the higher it is. In terms of natural supplements, there's a little bit of evidence that things that improve the blood supply to the uterus may be of benefit. Aspirin, 75mg of aspirin, and vitamin E supplements. Those are the two. And possibly even, again, not great data, but possibly even acupuncture again in terms of improving endometrial blood flow. But definitely vitamin E and baby aspirin are the two.
And so you're saying that people can just take aspirin? Should they?
Well, yeah, I wouldn't take aspirin with the vitamin E supplements. Yes, so aspirin will be in would be in the context of with a doctor trying fertility treatment.
I was going to say you'd have to,
Yeah, sorry, I should have clarified.
Go via a doctor, because I myself did start buying loads of aspirins once, and I know my doctor was like, you can't just
and definitely don't take
self-medicating.
Yeah, don't take aspirin, without a good cause in general for IVF, because it hasn't really been shown to improve outcome, and it can potentially increase the risk of bleeding egg collection.
Yeah. Okay, so only do it if doctor recommends. Thank you, Laura.
Question here about higher doses of stimulation. Does it affect the egg quality, especially for people with low reserves?
Yeah, no, would be my straight answer to that. I think the first thing to say is that every study ever done shows that the more eggs you get, the better the outcome. Simply because only, unfortunately, a small proportion of any woman's eggs are going to be genetically normal. So the more you get, the better the outcome. And although there is a place for things like natural IVF, if you're bombarding a woman with lots of drugs, which is only getting one egg anyway, it's a no-brainer. Natural IVF is an option. Some people, dare I say it, push natural IVF, not always when it's in the best interests of the patient, dare I say it. If you recommend some people to have natural IVF, it's a way of also making people not appear on the data in your success rates. But if you have got the ability to get 3 or 4 eggs, or 2 or 3 eggs, it's still going to give you a better chance than 1. So that will still be my default. Really nice study I actually read last night, looked at the proportion of embryos that were genetically tested and compared it in outcome by whether a higher dose or whether a lower dose was given. It showed no significant difference. There are studies that have said different things, but across the board, the more eggs you get, the better. So if you genuinely can get 3 or 4, even that's with a higher dose, I would.
I'm only going to take one more question now, Laura, because it's 5 to 9 and I don't want James to have to sleep in his office. So one more, please.
Okay. This is oh gosh, hang on. Sorry guys. This lady has a cycle between 27 and 33 days, and she's been told because she ovulates regularly, Clomid is not recommended, as you explained. But are her cycles regular?
Oh, if I would be writing regular-ish in my notes, and that's really unscientific. But the answer is they're regular enough. I think the problem is that from ovulation to period should be relatively regular at 14 days. What varies in women who ovulate is the first half of the cycle and how long it takes to get the egg ready.